First of all, is thanks for inviting me into this wonderful lecture. And from the slides, there are a lot of interesting points I learned from the two lectures. And as we go into the role of IVF in polycystic ovary patients at risk of hyperstimulation, we have a lot of fundamental issues which we did not answer as clinicians. We did not define what is a high responder and what is a polycystic ovary. If you take the Rotterdam criteria and the NIH criteria and the recent couple of years back, the combined ASRM and X-ray guidelines, and if you put the Pcos patients in that, they don't match. Suppose if you take Rotterdam criteria and put them into the current ASRM and X-ray guidelines, 42% become ineligible for polycystic ovary. In that situation, in the beginning itself, we are making a judgment error. Checklists for diagnosing are not uniform across the world, and then the clinician might select what they feel comfortable with. The second thing is you have another group of problems where you have different phenotypes of polycystic ovary, be it the group A, B, C, and D. And finally, you have other causes which are health related can also produce an ovary which is looking at polycystic ovary. So the outline of the talk is to rule out secondary causes of PCO, then the impact of age, BMI, antral follicle count, and AMH on OHSS, the role of metformin, and there are a couple of nomograms for prediction of polycystic ovary, and which type of control of LH, be it agonist or antagonist, and how do we decide a starting dosage, and are we using any fixed criteria and saying this is my starting dosage, and then a very little about polymorphism. Then I move to the ovulation trigger, then the consequence of ovulation trigger and its effect on the luteal support. Finally, what are the implications and benefits and risks of resolve? That's my outline of my talk. So when you look at the Rotterdam criteria and the ASRM combined X-ray guidelines, we are missing a large group of patients who are regular cycles, have good ovarian volume, and if you put them into the AFC percentile, they fall at 70th percentile. But if you do the dosage adjustment, starting dosage, they will give adequate usage but do not go into hyperstimulation. But that situation is completely different in a polycystic ovary. A hyperresponder is a healthy patient, whereas a polycystic has a dysfunction in the metabolic pathways. These two are different groups, and when we evaluate, we should have clarity about that. When you're looking at specific phenotypes, the phenotype D, with ovulatory dysfunction and a normal ovary, is not reflected in the literature we see. The literature says polycystic ovary, and the literature does not say how much is the AMH, how much is the antral follicle count, and what is the antral follicle count towards the oocyte output ratio. So there we get different reports by different people, and on top of it we have an ethnic variation. So when we look at polycystic ovary, we are having one is the definition itself, the second thing is the phenotypic variations, the third is a primary polycystic ovary fits either the Rotterdam criteria or the X-ray guidelines, and the secondary, which can be caused by all of these, be it hyperprolactemia, thyroid, adrenal hyperplasia, Cushing syndrome, acromegaly, and a severe form of insulin resistance. These can be corrected, and then you see a change in the antral follicle count. So this group, are we checking it? Because when we go for an antagon protocol, we just ask the patient when the patient is ready to come on the secondary cycle to start after the necessary documentation. But are we looking at this information to rule out whether a woman has a predisposition of a potential dysfunction which is looking at more follicles? What are the factors that can keep a patient at risk? And we say age is not a factor, but there are studies in younger women less than 25 years. There is an increased risk of ovarian hyperstimulation, but that does not apply to women above 25 to closer to 40. So, as the society's age has increased, for example, 15 years back, my average age of the patient was between 22 to 34. Now my average age of the patient is 29 to 39. With the demographic shift, this group who are at risk because of age are disappearing as a potential cause for predisposing for HSS. Then this is an interesting study which I might differ with the previous speaker's opinion about a fixed dosage. Here these charts show these are four groups of patients: a lean patient with a normal ovary, a lean PCOD, an overweight normal ovary, an overweight PCOD. And this group of researchers have given 75 units of FSH and measured the threshold of FSH based on these groups. If you look at the overweight PCOD group, that is the orange line, her threshold has not reached a particular point. And in these situations, sometimes we may not reach the therapeutic window of the FSH to do the recruitment. So that is one area where looking at BMI and looking at the PCO and then deciding the dosage, because if this study is accurate, then just using AFC and AMH may not be adequate to give the exact dosage. You might underdosage or overdosage it, and then down the line you can correct it. But that's vastly different from putting a dosage at the right point and continuing it so that you have a cohort which uniformly goes up. Then you have another area where anti-Mullerian hormones and the risk of OHSS. There's a beautiful article in the American Journal of Obstetrics and Gynecology. And then this group are correlating the level of AMH with the polycystic ovary phenotypes. And in this situation, what happens is there in a phenotype where the patient had AMH5 compared to a phenotype which had AMH more than 10, the risk of hyperstimulation is vastly different. So in this group of patients, looking at AMH, looking at antral follicle count, looking at BMI, and looking at multiple factors, and then trying to study the various impacts of these factors and come to a common protocol in each individual clinic will help to minimize overstimulation, which lands up in a mess of hyperstimulation, or understimulation, which lands up with few sites or cancellation of cycle. Again, there is one more thing is, when we review the recent literature in the last 2-3 years, when the guidelines of the polycystic ovary by the neuro recommendations, they put a cutoff level of almost 40 follicles in the both ovaries put together. But there is a significant large amount of data showing the antral follicle count above 24 correlates with increased risk for moderate to severe hyperstimulation. So there is an interesting article which is published in 2020 in the Human Reproduction, where this group argue that by putting it at a large number of antral follicle count, we are missing a huge spectrum of population, and then not stimulating them as polycystic ovary but as normal women, then ending up with a catastrophic situation. There are a couple of prediction models that are being said. Here in this prediction model, they're looking at the basal FSH value. If it is high, when the reserves are low. Similarly, the AMH. They are also looking at if there's a previous cycle, how much amount of gonadotropins are used. They are also looking at antral follicle count, and based on that, and at the beginning of the cycle, they're looking at the number of points these patients reach, and then looking at the possible risk of hyperstimulation. So these predictors, with the AI model the previous speaker suggested, will improve the quality of stimulation protocol and the right dosage. Then comes the metformin, which in favor for 1 decade goes out of favor in 1 decade. But here there are a couple of studies which show if metformin is given for a period of 6 months, then in these patients the AMH value is decreasing from 11 to 7.4, and the antifollicle count is decreasing from 13 to 9.8, which is published in the JCM in 2011. That means if you have a high risk patient with androgen excess, with high AMH, the role of metformin will help you to have a better control on the cycle. Then when we look at the actual, till now we have spoken about the identifying the risk factors, then we are looking at which protocol to take, as all of you agree, the antagonistic protocol. Then in the past 3-4 years, the onset of progesterone as a LH suppression is coming up, and the limitations of a minimal stimulation. As everybody agrees, the method to reduce the risk of OHSS is to use antagonists to suppress pituitary LH. And this paper does not say don't use it, don't use long protocol, because different parts of the world practice different down regulations. For example, when you look at China, there is a significant large number of population whose protocols are long protocols, and they're getting equally satisfactory results. So in a polycystic ovary, till we understand the pathology, we'll be struggling with different types of protocols. Then in the persistent, if the woman is given from the day 3, 10 milligrams per day of medroxyprogesterone from third day of the cycle to the day of SCG, then there is absolutely LH suppression. Then it can be followed by a GnRH, which is promising, but the only disadvantage is you can't transfer any embryos in this cycle. That means in this protocol, you are forced to do only freeze-all. Unlike an antagonist, you have a choice of free and fresh or frozen embryo. These are the strengths and weaknesses of the progesterone to block the LH surge. And if we look at the weaknesses, it's only freeze-all strategy. Then one important thing is, unlike antagonists with a decreased total dosage of gonadotropins, here there is almost 400 units of difference of gonadotropins more is needed. Then the third thing is your cryopreservation practices. These are the weaknesses, and strengths. For every study the strengths are there, which we know, and one should balance between the strengths and weaknesses in relation to their particular practice. What is the choice of FSH? There are not many studies on PCO with a prospective trials except this study of FSH versus HMG. But as the world is moving away from HMG, the choice of recombinant FSH is becoming predominant. So this is only a theoretical choice. Then we come to the starting dosage. In the starting dosage, this is what we do in our practice. This is you take an arbitrary dose of FSH, then in the age, you take 30 years as the mean. So the woman is 25, then you minus 25 units, woman is 20, you minus 50 units. Similarly, if the woman has a BMI of 22, then you minus 25. That way, you're able to reduce the dosage of your stimulation sometimes as low as 75 units of FSH and still get good recruitment with practically except one patient we did not have any cancellations in PCO. If you look at the antral follicle count, where we take 8 to 16 as a stable dosage, and if it's more than 16, we reduce the dosage. Then if it's more than 25, we further reduce the dosage. If we are increasing it, we totally never cross 300 units. But when we are decreasing it, we go as low as 75 units by using this method. And this is an arbitrary method because these responses will differ from product to product. And we have a policy of using only one gonadotropin product, and we also insist they provide us with the batch number so that we are also tracking the batch to batch variability when we are fine tuning this way. And this is helping us drastically minimize hyperstimulation, because when I said minimize hyperstimulation, because when I say there is no hyperstimulation, then what is our criteria for mild hyperstimulation? Then the trigger type, the HCG, the GnRH, or the combination of GnRH with low dose HCG. The data in the Cochrane database of GnRH agonist versus HCG, except for the elimination of hyperstimulation, there was no difference. But when it came to the actual reality in the later years, it was realized that these patients have disturbed luteal phase and they need a modification. So when you look at all the articles, you can summarize it. The stimulation protocol is: one is Einstein hyperresponder plus a sickness of PCO. Adjust your dosage, correct the modifiable factors, and give a GnRH agonistic trigger at the right time, and then do a fresh embryo transfer with a modified long luteal phase support. What that means is adding HCG, which I'll come in a minute. The other method is just take the oocytes, fertilize it, and freeze and transfer it to the next cycle. For each of them, there are advantages and disadvantages, which I'll be highlighting. One of the options of luteal support, which has not been perfect but helped some other groups, is a single bolus dosage in the luteal phase. But when it comes to as a perfect luteal support, this is a work of Peter Humayden, where if he gets less than 40 or 14 oocytes in an antagon protocol, he gives 1500 units of HCG at the egg pickup and 1000 units on the day of egg pickup, followed by 5 doses and a standard luteal phase. That means micronized progesterone tablets, 2 per day. If he gets 15 to 25 oocytes, then he gives 1500 units of HCG at egg pickup, but no more HCG, but only micronized progesterone in the luteal support. When he gets 26 to 30, he gives, apart from the GnRH trigger, 1000 units of HCG at egg pickup, followed by a standard micronized progesterone luteal support of freezol. And when he gets 30, he does freezol. That means when we have moved from the other protocols, we had a trade-off of reducing the risk of hyperstimulation, but a disturbance of the luteal phase support. And at this moment, the whole community is trying to find out what is the best luteal support. The answers are yet to come. There is another interesting fact about freezol. This is a wonderful article that was published in the New England Journal of Medicine. The title of the article is Fresh versus Frozen Embryos for Infertility in Polycystic Embryos. And these group had surprising findings where they only change the wording is we have eliminated OHSs by doing freeze-all, but only we faced is in the frozen embryo transfer cycles, we're increasing the risk of preeclampsia, which data I'll present it in a moment. So in this group, when you look at maternal, fetal, and neonatal adverse events, the preeclampsia among the clinical patients in the frozen transfer group were 4.4%, and in the fresh transfer group it was 1.4%, and a p-value that is significant. So there is an emphasis that freeze-all has its own limitations apart from the benefits, and I think we should discuss the patient in a different way, which I'll come to the concept of segmentation. We never segment the counseling into these parts, so that depending on the situation, if you segment it at the time of discussion for over-respondents, patients or hyper-respondents, or patients with a Pcos with AMH5, there discussing the option of segmentation will give better comfort to the patient and also better flexibility for us to give a safe travel and a good birth, at the same time minimizing the potential risks that are flagged in the New England Journal article. And with that, I convey a warm wishes from Visakhapatnam for my team of Krishna IVF. Thank you.